Syphilis is a chronic, systemic infection caused by the spirochete bacterium Treponema pallidum. It is primarily transmitted through direct contact of infected mucous membranes or skin lesions during vaginal, anal, or oral sexual activity. Vertical transmission can also occur from a pregnant woman to the fetus, leading to congenital syphilis. The disease progresses through distinct clinical stages if left untreated, each with characteristic manifestations. Understanding its transmission dynamics, natural history, and public health impact is essential for effective control and prevention. The sole etiologic agent of syphilis is Treponema pallidum subspecies pallidum, a motile gram-negative spirochete, approximately 6 to 15 micrometers in length and 0.1 to 0.2 micrometers in diameter. Its unique corkscrew shape and periplasmic flagella enable it to penetrate intact mucous membranes and disseminate rapidly through the bloodstream. The bacterium lacks many metabolic pathways, relying on the host for nutrients, which explains its obligate intracellular lifestyle. No other microorganisms are required for disease development, though co-infection with HIV or other STIs can alter clinical presentation and progression. After inoculation at the portal of entry, T. pallidum quickly enters the local tissue, evading innate immune defenses by cloaking itself in host proteins. Within 24 to 48 hours, it reaches the regional lymphatics and then the systemic circulation. The spirochetes disseminate hematogenously, seeding skin, mucous membranes, the central nervous system, cardiovascular structures, and bone. Their outer membrane proteins trigger a delayed type hypersensitivity response that produces the characteristic canker in primary syphilis. If the infection persists, immune-mediated vasculitis and tissue destruction lead to the rash of secondary syphilis, and later the gummatose lesions, neurosyphilis, or urtitis seen in tertiary disease. Syphilis remains a global public health concern, with an estimated 6 million new cases worldwide each year. In high-income countries, the burden is concentrated among men who have sex with men, MSM, and individuals with HIV co-infection. While in low-resource settings, the disease predominates among women of reproductive age, contributing to congenital syphilis. In the United States, the CDC reports roughly 1.5 million cases annually, with notable spikes in the 15 to 44 age group. Socioeconomic factors, such as limited access to screening, stigma, and inadequate prenatal care drive disparities in incidence and outcomes. Syphilis evolves through 4 clinical phases. Primary syphilis, approximately 3 to 4 weeks post-exposure, presents with a solitary painless canker at the inoculation site. It is hard, well-demarcated, and may go unnoticed. Secondary syphilis, weeks to months later, is marked by a diffuse maculopapular rash often involving the palms and soles, mucus patches, condylomata lata, fever, lymphadenopathy, and sore throat. Latent syphilis is asymptomatic but serologically positive. Early latent, less than 1 year, remains infectious, whereas late latent, greater than 1 year, does not. Tertiary syphilis, years after infection, can produce gummatose lesions, granulomatous skin or organ masses, cardiovascular disease, urtitis, aneurysm, and neurosyphilis, tabes dorsalis, general paresis. The progression underscores the importance of early detection. Diagnosis combines serologic testing with direct detection when lesions are present. The algorithm typically starts with a non-treponemal screen RPR or VDRL that detects anti-cardiolipin antibodies. Results are quantified as titers to monitor treatment response. Positive screens are confirmed with treponemal assays, FTA-ABS, TPPA, or chemiluminescence immunoassays that detect antibodies specific to T. pallidum proteins. In primary lesions, dark field microscopy or PCR of exudate provides direct visualization of spirochetes. Interpretation must consider the stage of disease, prior treatment, and potential biological false positive results. Syphilis is classified solely by clinical stage, rather than by distinct pathogen subtypes. The 4 stages, primary, secondary, latent early and late, and tertiary, reflect the temporal evolution of symptoms and the organism's tissue distribution. Each stage may have overlapping serologic profiles, but the management strategy is dictated by the stage due to differences in infectivity and risk of organ damage. No separate types, such as bacterial strains, are clinically relevant for routine practice. The cornerstone of syphilis therapy is a single intramuscular dose of benzathine penicillin G, 2.4 million units, for early disease, primary, secondary, early latent. Late latent and tertiary syphilis require 3 weekly injections of the same dose. For patients allergic to penicillin, doxycycline, 100 milligrams, orally, twice daily for 14 days, early or 28 days late, is an alternative, while ceftriaxone may be used in certain settings. Pregnant women must receive penicillin regardless of allergy due to fetal safety. Follow-up serology at 3, 6, and 12 months, or longer for late disease, monitors decline in non-treponemol titers. A 4-fold decrease indicates adequate response. Persistent titers warrant retreatment and evaluation for neurosyphilis. Primary prevention hinges on barrier protection, regular screening, and risk reduction counseling. Correct and consistent condom use drastically lowers the transmission probability of T. pallidum during vaginal, anal, and oral sex. Routine serologic testing every 3 to 6 months for high-risk groups, MSM, sex workers, HIV-positive individuals, facilitates early detection and treatment, breaking the chain of transmission. Partner notification and treatment, expedited partner therapy, further limits spread. In pregnant women, early pregnancy screening and prompt penicillin therapy prevent congenital syphilis. Public health campaigns that destigmatize testing and promote sexual health education are essential adjuncts. When identified and treated in the primary or secondary stage, syphilis is curable, and patients typically experience complete resolution of symptoms without sequelae. Latent infection that receives adequate therapy also carries an excellent prognosis. However, delayed or incomplete treatment can lead to irreversible organ damage in tertiary disease. Cardiovascular complications, such as aortic aneurysm, neurologic deficits from neurosyphilis, or destructive gummatose lesions. Congenital syphilis can cause stillbirth, neonatal death, or long-term developmental impairment. Hence, prompt diagnosis and adherence to treatment regimens are critical determinants of outcome. Point-of-care lateral flow assays now deliver results within 10 to 15 minutes, facilitating same-day diagnosis in low-resource settings. Genomic sequencing of T. pallidum isolates enables real-time tracking of outbreak clusters and antimicrobial resistance patterns. Vaccine research is focusing on conserved outer membrane proteins, for example TP0751, TP0470, to elicit protective antibodies, with several candidates in preclinical evaluation. Additionally, novel antimicrobial regimens, such as single-dose ceftriaxone, are being investigated to simplify therapy for patients with penicillin allergy.